will kick off the IPA's webinar series on teen and young adult health. So without further ado, let me introduce our moderator for today's presentation and thank her for all of her hard work putting this together, Dr. Preeti Galagali from India. Preeti?
I'd like to introduce
Yes.
Dr. Warren Sehgal, please introduce Dr. Preeti Galagali.
Sure. So Dr. Preeti Galagali is the Vice President of South Asia International Association of the Adolescent Health, IAH, and practices in India as the Director, Bangalore Adolescent Care and Counseling Center and lead adolescent clinic, Manipal Hospital. She's one of the first Indian pediatricians to be formally trained in adolescent medicine and is a pioneer of comprehensive adolescent health care in India. She has co-authored the first clinical guidelines for adolescent health, digital wellness, and child protection under the aegis of the Indian Academy of Pediatrics. And she was the Vice President of the IAP in 2025.
Thank you so much, Dr. Warren, for that fine introduction. As we begin today's webinar, I would also like to introduce a very important guest, Dr. Maria Carmen, who is the president of the International Association for Adolescent Health, and she's also the chair of the NCD and Adolescent Health Committee of the IPA. We would start this webinar with opening remarks from her. Dr. Maria Carmen.
Thank you, Preeti. I am, dear distinguished colleagues and dear friends, it is both an honor and a responsibility to speak to you today as the coordinator with Dr. John Klein of the NCD Adolescents and Mental Health Committee of the International Pediatric Association and as president of the International Association for Adolescent Health. We gather at a critical moment. Around the world, more than 1 billion adolescents are navigating one of the most transformative stages of life. Today, I invite you to consider a fundamental shift from asking what is wrong with this adolescent to asking what is strong in this adolescent. Let us begin with a simple truth. Risk-taking in adolescence is not a failure. It is part of development. The adolescent brain is wired for exploration. Their behaviors are shaped by families, by schools, by communities, and by digital environments. So our communication must extend beyond the clinic. This is not only a clinical skill, it is a system responsibility. We must embed a strength-based, autonomy, supportive communication into training, into policy, into health systems, because the evidence is clear. This approach works. It improves engagement. It supports mental health. It reduces risk behaviors. But more than that, it changes how adolescents see themselves, not as problems, but as people with potential. And that is where lasting change begins. So I leave you with this. If we want healthier generations, we must change not only what we say to adolescents, but how we see them. Thank you and welcome.
Thank you so much, Dr. Maria Carmen and Dr. Sehgal, for your inspiring addresses. Definitely, a strengths-based approach and trauma-informed care would build up a therapeutic alliance between the teen and the provider. And as we have already mentioned, that adolescents are individuals with assets, capability, and agency, and how they stay risk-free in this wonderful and challenging period of life is what we give anticipatory guidance for. And we have wonderful speakers today, and I would request Madhumita to please share their bio slide. Thank you, Madhumita. Can you please put it full screen? Full screen, please. Thank you. So our first speaker would be Jerry Karija. She is a consultant pediatrician and adolescent medicine specialist from Nairobi, Kenya. She's passionate about providing timely and evidence-based preventive promotive healthcare to adolescents and young adults. She also supports parents, educators, and healthcare workers to be better prepared in their care of 10 to 21 years old. She serves at the Aga Khan University Hospital, Nairobi, and is a board member of the Kenya Pediatrics Association. Our second speaker, can you please change the slide? Madhumita, can you change the slide, please?
Yes, Dr. Preeti, I'm
Thank you. Thank you. Our second speaker would be Paul Divine Boton, and he is from United States of America. Can I have his slide, please? He serves as a faculty at the University of Pennsylvania. And as we all know, it is Earth Day tomorrow. Very interestingly, he believes in helping adolescents and young adults to overcome the ongoing crisis in our climate and environment, teaching and advocating for practices and policies that will advance well-being of the earth and all its inhabitants. Wonderful indeed. We look forward to listening to you. So I would now request Dr. Jerry to give a presentation on confidentiality. Over to you, Dr. Jerry.
Thank you so much, Dr. Galagali, and thank you so much to our preceding speakers in the introduction. So I'll request if you could be able to project the slide, and I hope you can hear me well. To those who logged in, my apologies. My connectivity has decided that it's either to see my face or to hear my voice, and so kindly allow me to be able to speak with my video off. If we could go to the next slide, please. So I'd like to make an acknowledgement to the African Adolescent Medicine Consortium in the preparation of the slides for the confidentiality and trauma-informed care of the adolescents. Next slide, please. Next slide.
just a minute.
No problem, Adinita. While you're doing that, is it okay if I just continue to speak? Would that be okay?
Yes.
All right. So we will be talking about confidentiality and the adolescent, and then my colleague, Dr. Baton, will take us through the strengths-based approach for the adolescent, and then we'll circle back and talk about trauma-informed approaches in adolescent provider communication. So we'll define confidentiality, we'll talk about the quality standards of adolescent healthcare. We'll also look at the adolescent brain and decision making, and then look at some contextual provisions and the role of confidentiality before I hand over to my colleague. All right, next slide, please. Are we okay to continue? Yep, next slide, please. Yeah, thank you. So when we think about confidentiality, it's that agreement between the patient and the healthcare provider concerning information that is to be discussed during medical encounters. And this cannot be shared, or ideally should not be shared, without the patient's explicit consent. And this is from the SAM position paper all the way back in 1997, but still rings true till today. We recognize that it's a foundational element when we think about high quality care and accessible care for adolescents. And then when we think about confidentiality, we do need to differentiate it from consent, because when we think about confidentiality, it's being able to keep that health information private, whereas consent is looking at the individual's ability to be able to make decisions around their health. Next slide, please. So while the next slide comes up, when we talk about quality healthcare, we think about the global standards for quality healthcare services in adolescents, and we think about it from the perspective of the World Health Organization that defines good quality healthcare in these 9 quality standards that had been developed through this thorough process of literature review and consultation with experts. So when you look at the different global standards, there are those that I have highlighted there. We talk about adolescent-centered care, developmentally responsive care, inclusive, confidential, respectful, and safe care, family and community engagement, competent workforce, and those first 5 actually stand out when it comes to the considerations around confidentiality. When we think about adolescent-centered care, confidentiality is at the heart of adolescent-centered care because we are focusing on rapport building, we are focusing on what they're able to do at their developmental stage, and actually focusing on the young person rather than focusing on their parents or their caregivers at that point in time. When we think about it from a developmentally responsive perspective, you're thinking about that growing and developing and evolving autonomy of the young person. And so you want to be able to think about this also being at the core of standard number 2. But then I really focused on the inclusive, confidential, respectful, and safe care that has 3 statements to it that are projected there before you. And this first statement talks about treating all adolescents with dignity and respect. And then the second statement within that is providing confidential care at all points of contact. When we think about a lot of our clinic settings, we think about confidentiality mainly being when the patient comes into the room and you're able to negotiate in terms of being able to have a private space. But what this statement actually says is that it extends beyond that room and thinks about that environment from the time they walk in and they encounter the very first person at the first point of contact in the healthcare setting. We look at adolescents and their caregivers getting to understand their rights to confidentiality and the limitations of that right, and we'll discuss that in a little bit. And then we look at the third statement that talks about prioritizing the safety of the adolescent by creating this supportive, inclusive, and culturally informed environment, which when we think about it in terms of confidentiality, we must ask ourselves from a culturally informed perspective. What does that look like in the African context? What does that look like in the American context, in the Asian context, etc.? What does that actually look like, and how can that be executed in a way that is respectful, in a way that supports the adolescent's choice to come into the space and be able to share their needs with us? The next slide, please. So on the next slide, I'd want us to shift gears a little bit and talk about the brain development and how adolescents make decisions. At the beginning, we had talked about the difference between confidentiality and consent. And sometimes in some scenarios, people do mix the two, but it's important to be able to note that while the adolescent is growing and developing, and the research is showing us that this development happens from back to front, and we have the limbic system that ends up developing at a much faster rate than the prefrontal cortex. And this development has been demonstrated to complete at the age of 24. What the research is also showing us is that the young people are cognitively able to understand medical decisions in terms of being able to understand what the pros are, the cons are, by about mid-adolescence. However, because of the way the maturity of the brain happens from back to front, we recognize that there are certain states that would affect their ability to think. So when we think about hot cognition, these are the things that cause, an emotional raise for them, and it could be something that has happened that has, excited them excessively or has caused an extreme amount of emotion in terms of anger or sadness or a significant amount of frustration, which we have seen and has been demonstrated to cause this flooding of the prefrontal cortex, and then it's not able to then uh, make this cognitive and balanced in terms of some of the decisions. And so in certain circumstances where we call the hot cognition, some medical decisions, however, at cold cognitions, when things are calm, when the stakes are much lower in terms of what the emotional input might be, they're then able to make better decisions. So it's also important when you have young people coming into the clinical space to actually ensure that we are not in a state of hot cognitions and then asking them around the areas around confidentiality. You would actually want them to be calmer and be able to then be able to make a rational decision around whether they want to have that confidential space, whether they want to give permission about certain elements of their care. The next slide, please. So when we think about the provisions of confidential healthcare, what I love about the panel that is in front of us, I think all the different areas around the world are represented here, at least most of them are represented. And what we do recognize is that in terms of state and federal laws, there are different laws that govern, age of majority. And in some states and some countries, that is age 16, others 18, others 21. It's important for us as clinicians to be very clear about what the law indicates in our context, and not only what our law states, but also what the provisions are for you as a healthcare worker, and ways that you can be able to partner with a young person and their family within the context of the law. The other thing that also supports the provision for confidential healthcare are healthcare policies that have been set up in our countries, that have been set up as global standards by various organizations, and the important inputs that they have in terms of the recommendations that they give. We find that the healthcare policies cannot trump the law, and so it's important for our context to be able to know and make that balance in terms of some of those decisions. I'll give an example. For instance, in Kenya, the Children's Act actually states that everyone under the age of 18, decisions are made for them by parents or guardians. Okay, but then when we look at some of the healthcare policies, for instance, in terms of HIV testing, HIV testing has been recommended to be able to be done for everyone under the age of 18 without necessarily having parental consent. So when you look at these two things, you look at the way the law does govern over that particular policy, because at the end of the day, we look and say that the law supersedes that particular policy. So I'm just giving one of the examples that's more familiar to me, but I'm sure if you were to go, within the chat, you'd find that there are these different things between the state laws and also healthcare policies. And then we think about the ethical principles that also govern confidential healthcare. Next slide, please. So when we think about the ethical principles that support confidentiality, we think about autonomy, and this is where healthcare providers need to be able to respect adolescents' developing capacity to make decisions and recognize this capacity is dynamic. And then when we think about beneficence, we also think about seeking the best interest of the patient. And sometimes to be able to do that, you need to be able to negotiate for that confidential space to be able to make it safe for them. The next slide, please. And then we think about non-malfeasance, but non-malfeasance, when you think about it, we want to avoid doing harm to the patient. However, it does have to happen in the context of autonomy and beneficence. And then we do want to give adolescents a fair and reasonable opportunity to receive the care that they have come into the healthcare space for. Next slide, please. So when we think about all those elements in terms of how we've defined it, and also the ethical principles and the legal and policy aspects, we think about the limits of that confidentiality. And it's really important at the beginning of your consult to be able to express that there are limits if the adolescent safety is at risk, if we are reporting a certain communicable disease for public health purposes, if there is disclosure needed due to a court order, or if the adolescent gives permission for that information to be disclosed. It's really important to be able to build that trust and confidence of the young person in you by being able to put this at the beginning, because you're not surprising them towards the end that there are these limits, so that they go into that healthcare space understanding that there's this safe space that's being created, there's this rapport that's being built. However, we want to be able to prioritize their safety and the safety of those around them, even as they're trying to respect that confidentiality aspect. Next slide, please. Very quickly, in terms of provisions, we have talked about the differences based on geography, the age of the patient, considering the age of majority versus capacity to consent, and the legal status, understanding emancipation, mature minors, incarcerated minors, and the laws that are around that, and then the type of service needed. Usually the most straightforward services, there is not much problem with that, but then when we come to certain sexual reproductive health situations, mental health situations, and behavioral health services, we find that there might be a bit of a limit. Next slide, please. So this is what I call a sticky slide. This sticky slide, I just want to describe it. This was data from 2022 that looked at age of majority versus age of sexual consent versus the age of access for HIV testing in Eastern and Southern Africa. The blue represents the age of majority. So that ranges from age 18 to about age 21. And then the orange represents age of sexual consent, and the red represents age of access for HIV testing. So I will pick Kenya because I'm from Kenya, which is the 1, 2, 3, 4, 5, 6, 7, the 7th country. And as you can see, the age of majority is higher than age of sexual consent and age of access for HIV testing. So just as a correction, age of sexual consent and age of majority are the same at age 18, but the age of access for HIV testing is at a much lower age group that's given there, which is at around 15, 16 years of age. And if you look across, you notice all these discrepancies, which then cause quite a bit of a sticky situation. And so at this point, I'd like to hand over to Dr. Botton in terms of when we have these sort of sticky situations and we want to be able to prioritize a strength-based approach, how would we go about it? Over to you, Dr. Paul. Next slide, please. Next slide, it's all right. Next slide.
Thank you. Yeah, thank you. Can folks hear me now? Seems better. Great. All right. Well, thanks everyone, and appreciate the introductions and this great discussion of confidentiality. And when we were putting these ideas together, it felt very natural to put these 3 elements in one presentation about adolescent communication, because they really are all different sides of the same issue, which is about how do we respect our adolescent and young adult patients, and how do we communicate in ways that show that respect and that help to sort of build the therapeutic bond that's going to move them towards adulthood. And so I'll be talking a little bit more specifically about the interview style, a strengths-based perspective in interviewing adolescents and young adults. So go ahead and click to the next slide, please. And I just want to apologize to everybody. When I made these slides, I was thinking about sort of clicking to show all these ideas, but because Ms. Madhumita will be assisting me with the slides, there'll be a lot of clicking required. So please bear with us. But this is really a question for everybody who's here today. I think one of the great things about this particular talk is, of course, that so many folks and cultures and countries are represented. But I do think something that's fairly universal is that we all, have different biases against adolescents and young adults. If you could click one more time, Madhumita, the question, is twofold, because we all exist in societies in which adolescents and young adults may face certain biases, but then we also need to recognize what biases we hold and what biases we bring into our encounters with adolescents and young adults. And so I think that a lot of what Dr. Jerry just was sharing about development and about how important confidentiality is really is the perfect segue into this conversation, because so many of our topics are stigmatized if we're thinking about key aspects of adolescent and young adult health, whether that's things like emotional, psychological well-being, or substance use, such as alcohol or nicotine, or sexual attractions and behaviors. And so, we are constantly, I think, needing to check ourselves and remember what we bring into these encounters and what adolescents and young adults have experienced even before they've gotten to our encounter. Let's go to the next slide. One more time. And so the framing that I think is so helpful for this topic and for really a lot of our conversations is positive youth development. And this particular quotation actually came from a presentation at SAM, which is the Society for Adolescent Health and Medicine, this past year, where a young person with rheumatoid arthritis who has become a really big advocate in her own space and for research and policy on her own disease, shared that she views positive youth development as viewing youth as resources full of potential rather than problems to be fixed, emphasizing strengths and capabilities over deficits. And so, anybody who has felt frustrated by a teenager, or who has, found themselves really thinking about, oh, this person in front of me is, just pushing me, or thinking about, all the risks that they might be taking, I think that we can always try to reorient ourselves more towards this positive youth development frame. Next slide. And just to echo something that Dr. Jerry said very beautifully, this is adolescents and young adults are at this very specific developmental stage where all of these things are particularly appropriate because their brains are truly developing, as evidenced, in imaging, over this time period, rather, more than they are really at any other time except in infancy. And it really is the executive functioning that comes last. And so there's all this sort of socio-emotional responsiveness. There's all these hormonal effects on the brain. And really it is not until it feels like it just keeps getting later and later. I feel like we thought it was 18, then 20, 25, now 30, when, the brain really has sort of like maybe reached its full development, and executive functioning really is fully present, or as present as it's going to be. And so just a reminder, that there really is a biological basis for teens' behaviors and the ways in which they react to so many things. Next slide. And so I think it's helpful to ask ourselves, what is the role of risk taking? Why do teens take risks? Why is it developmentally appropriate? And so just to really thinking about what benefits risk taking can have, you can go ahead and click 3 times. But there's the social function. So how do we all exist in this society? What by taking a risk, in a social encounter, what is that going to teach us about how other folks will react, or about what is appropriate, what is not appropriate, what is safe, what is not safe? And then, to on another level, there's this identity development question of, who am I? How do I fit into all of this? And, whether it's trying out for a sport or playing an instrument, there's all these sort of healthy ways in which risk taking can really contribute to identity development. And then there's the fun aspect, which I think often is also underappreciated. But so many of the behaviors that teens want to try, and that older caring adults ask them to be really careful about trying, can be fun. And so again, I think that it's just a helpful sort of thing to remember when we might feel frustrated, or we might feel even worried about what our teens are doing when they're with us in clinic. Next slide, please. So what do we mean when we say strengths-based? So as I already mentioned, it's this reference to positive youth development. And I do want to shout out the work, particularly of one of my colleagues, Ken Ginsberg, but many others, who have done quite a bit in this world of positive youth development and thinking about how we can reframe our really risk-focused perspective on adolescent encounters to more of a strengths-based perspective. But all adolescents and young adults, no matter who they are, they each has unique attributes, skills, lived experiences that are going to help them specifically navigate their life. And each youth is the only real expert in what that life is. And by listening and by trying to be, as present and as responsive to what they say as possible, we are showing how we care and how we can be supportive. So these same factors, social curiosity, emotional sensitivity, some of these things that sometimes, again, we might frame a little negatively about, oh, adolescents are so reactive or so sensitive, can really be the basis for these health supporting actions. So using this strengths-based approach reminds adolescents that we are there to provide support, but that they have their own resilience, their own strengths, that can be the foundation for how they approach different challenges or questions about their own health. Next slide. So when we, with strengths-based approach, there's a recognition that, as we've already said, risk-taking is developmentally appropriate. There's humility, which is obviously important in all of our healthcare practices, but particularly when we're engaging with somebody who, A, is at this very sensitive developmental stage, B, has maybe experienced, various things that may make them suspicious about their encounter with us or even with adults generally. And a lot of this we'll get to Dr. Jerry's next piece about how we use trauma-informed care. But C, when the topics that we so often ask these folks are sensitive and socially stigmatized, trust really needs to be earned in those situations. And if you find that an adolescent or young adult is unexpectedly open, that even might be a cause of concern as well, because they, may be relating to you in some way that may put them in a certain vulnerable spot, or, that may pose a risk to them in another situation. And so just keeping all of that in mind, is a helpful way to enter some of these encounters. And then there's purely the pragmatic perspective, which is that if anybody feels as though they are being heard and respected, as opposed to judged, they're just going to be more honest. They're going to help you help them. And so, keeping this mindset can really be important for that. Next slide, please. So when you're actually engaging a youth in this way, some things that can be useful are thinking about your questions and your responses. What the questions, normalize everything. If someone tells you that they have done something that, everyone else may judge, try to be the person who is going to say, okay, how are we going to approach this? So normalize behaviors, normalize things that are stigmatized, if only to then get that information so that you can then help your patient move forward. The questions should be accessible, and that can mean a few different things, but sometimes you need to use slang. Sometimes you need to use terms that, you may feel very unprofessional. It may feel uncomfortable, but, if your patient only calls cannabis or marijuana weed, then it's helpful to call it weed, just so that you're sure that you're communicating in a way that they understand. And you can say cannabis or weed, or use, multiple terms, but just making sure that you are using terminology that is going to be accessible is really important. And then questions, should be open in some sense. Now, sometimes an open-ended question for anybody, especially if you're coming at it as a medical professional and your patient is not a medical professional, sometimes too open of a question can be confusing. And so I like to think about, we don't want to ask leading questions such as, you don't smoke weed, right? Or you don't have sex, right? But you also don't want to necessarily leave the question too open such that, they're not even sure what you're asking. And so there's certain ways, that I'll reference in just a couple of moments about how we can think about our questions as more sort of just welcoming, open questions as opposed to leading questions. And then equally important as the question, of course, is the response and how we communicate that, what someone has just shared is fundamentally okay and is something that, no matter how stigmatized the behavior, something that we can sort of help them address or consider. And so absolutely at every step in this process, trying to be as non-judgmental, non-reactive as possible is very important. Trying to be empathetic and recognize that, again, even things like, things that may reflect a certain level of risk may just be either a patient's efforts to survive, things that they feel that they need to do to make sure that they are able to feed themselves, able to live in a safe place, all these are able to have a safe place, able to have a place to live at all. Or a way to manage stress, a way to cope with, whatever their particular living situation is. And that can be a whole variety of things. But, being as empathetic and really trying to find the way to relate as much as possible to what your patient is experiencing and why they might be doing that is certainly helpful. And then certainly be curious. And, if you are seeming engaged about not just what your patient is doing, but why they are doing it, then again, I think that's just another way to show respect and to show that you are really interested in knowing, how you can work with this patient on advancing their health. Next slide, please. And you can click one more time, but, I think asking a patient to use drugs is not a bad thing. You're asking an important question. You're getting at an important concept here. But if you were to try to reframe that in a way that, again, is a little bit more normalizing of certain ways in which patients might be using certain substances, is maybe a little more of like not as open of a question, but more of a question that does have some context to it so that patients are really understanding. You could try something like, have you ever used alcohol, weed, any other drug that you weren't prescribed to help manage stress, anxiety, or down mood? In framing it like that, you're just offering patients this explanation for, this is something that some other people do. This is something that this is a reason that some people might use certain substances. So, I think every teen, at least in America for sure, and I'm sure it varies, of course, quite a bit, but has been, given the message that, drugs are bad, drugs we have to avoid, etc. And of course, there's many reasons why we share that message, but it just does introduce this space between the medical establishment and our patients about what they are willing to share. Can you click one more time? And then depending on what the patient says, you can then segue into just social reasons, another reason why somebody might be using a substance. Have you ever used any of those substances socially, just with friends or family? And so again, there's sort of an openness to the question without leaving it so open that, a simple yes or no is just going to shut down the whole conversation. And if somebody does say, please, next slide. And you can click a couple of times since there's probably, I'll just get started while we're waiting for the next slide. But, I think, of course, we've all had, you can go to the next slide. We've all had moments where we were caught off guard, where we weren't expecting an answer, where our sort of medical brains did kick in, and you can go ahead and click 3 or 4 times. And we just have that immediate knee jerk, like, oh, we shouldn't intervene on this kind of response. Or even just we don't catch our face before our face says something before our mouth can. And so, we don't want to be overly accommodating and, give the wrong impression that we don't share some level of concern, but we also don't want to be overly disciplinary and shut down the conversation in that way. And so there's sort of this middle ground, again, trying to be non-judgmental and empathetic and curious, where someone just shared maybe, and again, for me personally, in my practice, cannabis, marijuana, weed is probably the substance that my patients are using the most. And so this is very specific to that. But, I think this could equally be used for nicotine or alcohol or really and whatever, might be more appropriate for you in your clinical setting. But asking, yeah, I know that people might use weed for a number of reasons. What does it do for you? Like, how do you use that? And that, instead of just saying like, hey, you got to stop smoking weed, that allows you to say, oh, are you experiencing significant anxiety? Are you experiencing, depression, something that is making you look for what we might consider a maladaptive coping mechanism, but something that can open up the conversation into what else can we be thinking about instead of this. Next slide, please. And then go ahead and click 4 times. So, then we're always moving towards behavior change. And this is where the strength-based approach really comes back to help us. And so we do want to make sure that we're not just giving a recommendation like, you got to stop smoking weed, but offering some context. Your brain is developing so much at this point in your life. We have concerns about how this might be affecting your brain development. And then connecting that to a strength that you have already maybe uncovered in your conversation and saying, you seem to really have, insights. Like, that's a strength, certainly, having insights into how marijuana helps you manage your anxiety. Are there other options that we could consider? And so you're empowering this young person in front of you. You have insights. You care about your brain development. How can we work together to use those things to find other approaches here? Next slide. And so similarly, and this is my last example before we get back to Dr. Jerry, when thinking about, are you sexually active? Another very stigmatized question, another honestly very uncomfortable question for a lot of us to ask, especially, depending on the age or any other quality of our patient. But similarly, trying to offer patients some normalization of, is this a patient who may not be having sex at all, or they may be having, they may have a same-sex partner, they may be having anal sex, they may be having, just oral sex, things that they are not comfortable necessarily disclosing. If you open that conversation, have you ever been sexually active, whether sex with a penis, vagina, oral sex like a blowjob, again, trying to include the term they may be more familiar, more comfortable using, sex in the bottom or butt, any other way, that allows that person to say, okay, well, this doctor, this provider is already aware that people might have sex in these different ways. So now it's a little more comfortable to introduce whatever they might be doing. Next slide. And then you can click a couple times. So, are you worried about becoming pregnant? Certainly something I heard a lot when I was in medical training from my senior providers. And so I think there's a different way to approach it. Of course, we're going to get back to how can we help this person with whatever reproductive choices are right for them. But starting to uncover some of, how they feel in their relationship, what are their strengths, maybe are they bringing to their relationship? Do you feel supported by your partner? Do you feel pressured to do things you don't want to do? That can be, again, a more welcoming and open place to get at something that's really important for health, as opposed to something that, we might be thinking immediately, we have to prevent this patient from getting pregnant. And then next slide. You can click 4 times. Just a reminder that we don't necessarily know what the patient's goals are. So again, we're being non-judgmental, we're being empathetic. we may think, oh, this is a younger patient and I don't want them to become pregnant before they're ready. But they may have concerns about birth control. They may have reasons why they are not as concerned about becoming pregnant as we might be. And so you actually connecting back to a strength. So you seem to be thinking a lot about how you can stay healthy in your relationship. Let me know if it would be helpful to have some condoms that you could take with you, or let me know if you are interested in thinking about options to prevent an unexpected or unplanned pregnancy. Is again building on that, thought or insight that this patient has already provided in this situation. And then my last slide. So to transition now to thinking about, I know we only have about 10 minutes, but thinking about how, we really can bring a trauma-informed approach to all of this. It is helpful, this may be very familiar to certain folks, but HEADS was often how we thought about a psychosocial history. Your home, your education, your activities, drugs, sex, suicidality, some heavy stuff, some complicated stuff. And I was taught this shades approach, which starts with strengths. And even if it's not explicitly saying what are your strengths, although you can certainly say that, thinking about before you get into asking patients about these really sensitive issues, how can you make sure that they are feeling safe? How can you make sure that they are feeling like you see them as somebody more than just the risks that they might take? And so thinking about their strengths, thinking about their interests, thinking about the activities, these things that are strength school, home activities before you're getting into more sensitive subjects gives you that context that you can then use to take the strengths-based approach that might be helpful if there are, things that you're going to want to address. So with that, thank you, everybody. And I'll transition back to Dr. Jerry, for our last segment on trauma-informed approach.
So thank you so much, Paul. So when we think about trauma-informed care, we're thinking about all the things that Paul has mentioned in terms of looking at the strengths and building that into the kind of assessment that you're going to do, but being mindful that through this assessment, it's important to be able to recognize and be able to address the effects of traumatic experiences that may have been experienced by a child and or an adolescent. Next slide. So when we think about a trauma-informed approach, we, next slide, please. So when we think about the trauma-informed care, when we're thinking about the shades, when we think about HEAD, we're really listening out for these resilient skills that tend to develop in the context of a protective, stable relationship. Well, that might be in the home setting, that might be in their communities. So you want to be able to pick these protective skills around thinking and how they're learning, elements of hope, how they have regulation around them and self-control, what modes of efficacy they might be, what forms of attachment they might have. And that might be from the home setting, from the school setting in terms of relational, with friends and peers. You want to be able to pick out in terms of developmental skill mastery, as well as what their form of social connectedness is. These are the things that we, listen out for, understanding that they're protective skills, and even in the context of having experienced a form of trauma. Now, if you start hearing the opposite of that when you're doing your heads and shades, like instead of them being able to learn and being able to think, and you start hearing that there's stagnation in terms of their learning and there's some regression in that, if there's loss of hope, if there's loss of regulation, if they're not as self-efficacious, especially in a particular age group, if they're having some attachment concerns that come out, as well as having that inability to master a particular skill and being more isolated, then we know that from that perspective and from the research that their protective skills have been sort of stripped away by this particular trauma experience that they may have experienced. Next, 2 slides. So when we think about trauma-informed care, we want to think about the 4 R's. We want to be able to realize that there's a widespread impact in terms of trauma. And we want to be able to recognize the signs and symptoms of trauma, even as we're doing our assessments of young people, and understand that it may go just beyond the young person to their families, and thinking about us in terms of our staff settings, and think about us as staff members and recognizing if we've experienced any trauma that we might be mirroring onto the situation. It's important to respond by fully integrating knowledge about trauma into our practice, and that is what we're hoping to do today, as well as thinking about it more conscientiously in terms of our procedures. And we do need to resist re-traumatizing our adolescents as we are going through this trauma-informed approach. And with that, allow me to stop there and revert back to Dr. Preeti for any questions or comments that you may have. Thanks again for listening to us.
Thank you so much, Jerry, and thank you, Paul, for wonderful presentations. As I can see that there are no questions in the question box right now, would Dr. Maria want to ask any question? Dr. Mari Carmen?
Yes, one thing that is troubling us is the social media. What about social media? How do we ask that? What is the correct question? What is the correct response? Something about that, please?
Paul, can you please take that?
Sure. Yeah. I think that much like a substance, because we do know that it has these addictive, qualities that we are only starting to understand. I think it's appropriate to ask patients, how are they using it, and really for what purpose? Like, what do they get from social media? Because I think particularly we are certainly aware of a lot of the risks, although it's still obviously an evolving area of research. But for a lot of, I think, more traditionally marginalized communities, there can also be a lot of connection from social media, especially populations that may feel very isolated in their home settings. Social media may be a connection to folks who think more like them, folks who share certain qualities that they really value. And so just sort of a blanket, like, don't use TikTok or whatever it is, may not be helpful. But at the same time, figuring out, is there impairment? How is it helpful for you? And then, do you ever find that social media gets in the way of you doing things that you need to do? Again, so sort of like how our substance use framing, is it something that it has caused you negative consequences? Is it something that has gotten in the way of accomplishing any of your goals? And that kind of just gives us a little space to then say, okay, so let's think about, how do we reduce that risk? How do we, try to cut down on this substance, basically, that that you've been using recently.
So thank you, Paul. So the focus is on consequences and impairment, and that would help us to further push for a behavior change if at all required. Dr. Siegel, would you like to ask any question?
Well, first, I want to thank both of you for incredible talks. It's so much easier to give an hour talk than it is to give a 10, 15-minute talk, but you both have done a wonderful job. I guess, I'm not sure if I have a question or a comment. I deal with a large immigrant population here in New York, and religious population, kids from families from India, Pakistan, Bangladesh, Yemen. This is New York after all. And I'm always struck, and you talked, Paul, you talked a little bit about biases. I'm always struck by the fact that some of my patients are so insulated because of the religion of their families that they don't really see the things that are out there. And sometimes I say to myself, well, that's a good thing. On the other hand, I start thinking, well, maybe they are not taking those risks that are so important in adolescence. Can you speak a little bit about the intersection between adolescence and religious communities and cultures, especially given the fact we have people from all over the world?
Jerry, would you like to take this question? Okay.
Sure.
Yes.
Yes, sure. That's a really good question. I think One of the things that we have to constantly be mindful of is just being culturally appropriate, especially when we're having so many of those intersections. And a lot of the times, especially with different cultures, is breaking down, the barriers around not understanding what the expectation is in that new clinical environment. And so being able to sort of like walk them through and give them a synopsis of what to be able to anticipate also helps them sort of navigate it much better without fear of, their religious beliefs or their traditional beliefs or their cultural beliefs being contradicted, in the clinical setting, where at the same time you're also really negotiating and partnering with them in the care, for these young people, even though their cultural backgrounds may be different from the one that, ascribe to or represent. So it's still always a work in progress. And what I love about patients is that they're always also open to educating us, even as we care for them. So with that, I'll pass that back to Dr. Preeti. Thank you so much.
Thank you, Jerry. So we physicians have a tightrope walk to really go there, because we have to ensure that the parent and the adolescent bonding continues, and yet we are open to the new ideas coming from the generation next. Dr. Haddad, you have a question, please? Please go ahead.
I have a comment on what Professor Warren said on religion and teens, and so I'm in a country where unfortunately religion is so heavily impacting our population, our teens. Believe me, here, even though they may go out and export themselves to many countries out, but when they come back, they will fight in the name of God. They will use the God for fighting against enemies, and so and so and so. So it is really difficult. There is a complexity, complicated relation between teens and agents when they come back to their resources. When they are out, they may be free, but believe me, when they come back to their origin or they are in their premises, that is another issue. We need to advocate for that very, very hard. Thank you.
Thank you, Dr. Haddad. So I think religion should pave the way for spirituality and peace universally. And that is what we need to all work for. So once again, as I summarize this wonderful webinar, starting right from confidentiality, ensuring that we talk about confidentiality right in the beginning of the teen provider communication and outline the limits very clearly, keeping the law and ethics in mind, and then shift on to a strengths-based approach, keeping positive youth development in focus, use the shades, also be curious, be humble, be humorous with the adolescent. Of course, be sure not to hurt them at any time. Keep our minds non-judgmental and invite them for a behavior change. And lastly, if they face any trauma, be sure that we bring them into the window of tolerance so that they can function optimally. So once again, I thank Jerry, I thank Paul, Mari Carmen, Warren Segal, Dr. Haddad, who brought so beautifully the element of universal well-being and peace in the country and in the whole universe, which we so much need. Once again, I wish all of you a very happy Earth Day for tomorrow. And I thank the IPA tech team for doing a great job. Thank you very much. We would welcome you to now fill up the feedback form. Can I have the QR code, please, Madhumita? And I would also like to tell you that the recording of this wonderful webinar would be available on the YouTube channel as well as the IPA website. I'm sure I'm going to do this. I'm going to see this again because there's so much to learn and there is so much to soak in. And thank you very much. I hope you all would fill up the feedback form. Madhumita, if you have any other instructions to be given, please go ahead.
Thank you, Dr. Preeti Galgali. Thank you all the speakers, moderator, and the coordinator of the subgroup, and Professor Haddad for such an insightful talk. And we request all the participants to fill the feedback form, as it is mandatory to get the participation certificate. You may also get the feedback form while closing the session. There will be option of give feedback. You can click on that. And as Dr. Preeti has already told us that the recording will be available on IPA YouTube channel and as well as on IPA webinar module. Thank you so much. Thank you, everyone. Have a good day.
Thank you very much. Bye-bye.
Thank you, Preeti.
Thank you,
Thank
Preeti.
you, sir. Thank you.